39 million deaths between 2025 and 2050 are estimated secondary to antimicrobial resistance. That's 3 deaths every minute. And also 3.4 trillion annual global losses by 2030. That's worse than 2008 financial crisis. Every day on our antimicrobial rounds, we make the same decisions every day. De-escalate, step down, stop, wait. But more than 75% of our time is really mechanistic, like looking for the record, the antibiotics, days of therapy, allergies, inflammatory markers, vital signs, cultures, and only 25% we make the decision. Steward invests this flow, so the AA agent absorbs the review and the clinician has more time to see more patients and also do more de-escalation that goes to less antibiotic pressure. I am Juan Mora, Antimicrobial Stewardship Lead at the University Hospital of General Frontera, and I built this solo, and I'm going to show you how Steward works. In this rare case, we have Carmen, 32 years old, that has a community-acquired pneumonia in her right lower lobe. We have right now, and the blood culture is positive for Streptococcus pneumonia, susceptible to penicillin, amoxicillin, ceftriaxone, and levofloxacin. And right now is with piperacillin tazobactam. The recommendation is to de-escalate after looking all the variables one per one. You can see every one of them that de-escalate and switch to oral therapy. So we can discontinue safely piperacillin tazobactam IV and switch to amoxicillin to complete 7 days of antibiotic therapy. So you can see a great example about de-escalation and oral sequentiation. Now look that stewardship doesn't always give you a direct response. Stewardship asks for some more questions about his active antibiotic therapy, the primary diagnosis or suspected infection. And now you can see that with that information, it makes the final recommendation that right now is to maintain current therapy with meropenem because the patient is septic, and we can still de-escalate until at least the fast test. So we can see the Escherichia coli is ESBL producing right now. We can then de-escalate. They also offer us some alternatives if that's the case, like ceftriaxone, or if the E. coli is ESBL, then continue meropenem and then treat with the same antibiotic. Here you can see the duration of the therapy. In this specific case, complicated pyelonephritis, 7 to 14 days, and when we can do the transition. So the architecture is pretty simple. We have a router and orchestrator that goes to Steward as the listener, then the FHR air agent, and then the general agent that has all the daytime and all the codification. Best thing about Steward is that it can be used with your local guidelines. Escherichia coli patterns is not the same in Madrid than in San Francisco, so you can use your local guidelines and make the same recommendations.